Good morning, and welcome to the very first installment of the Tulane Innovation Series. This virtual series will feature discussions by leading Tulane experts from the widest variety of fields, offering insights and solutions to today's greatest challenges and issues. Such discussions are an essential part of Tulane's mission. As stated in our motto, Tulane's fundamental goal is to communicate knowledge in order to empower individuals, organizations, and communities to lead with integrity and with wisdom. Never has this mission been more relevant than today as the world continues to combat COVID-19. Tulane has brought its 186 years of experience in fighting infectious diseases to the front line in the battle against this unprecedented health threat. This includes our healthcare professionals who are caring for COVID-19 patients, our researchers who are seeking new treatments, tests, and vaccines, and our epidemiologists who are tracking the origins and spread of this disease, plus many other dedicated scientists and scholars. This morning, we have three leading Tulanians who will kick off the new innovation series. Today's focus is COVID-19's health disparities and public impacts. Our guests for today, Thomas LaVeist and Susan Hassig, have been featured on many media outlets, publications, and expert panels to discuss the health disparities that specifically challenge minorities and vulnerable populations. Their fundamental goal is to not only overcome the COVID-19 pandemic, but to advance health equity for decades to come. Thomas LaVeist, Dean of Tulane School of Public Health and Tropical Medicine, is a national expert on equity in health. Prior to joining Tulane, he spent 25 years at the Johns Hopkins School of Public Health, where he was a professor and director of the Hopkins Center for Health Disparities Solutions. A member of the National Academy of Medicine, Dr. LaVeist was named co-chair of Governor John Bel Edwards' Louisiana COVID-19 Health Equity Task Force. He is also executive producer of the documentary The Skin You're In, which explores health disparities in America. Susan Hassig is a leading expert on infectious disease outbreaks, vector-borne disease, HIV, and associated infections. Prior to joining the Epidemiology Department at Tulane, she spent more than a decade working in HIV research, surveillance, and intervention programs in the US and around the globe. She also served in the Peace Corps, where she worked to improve disease diagnosis methods and blood transfusion safety in Thailand. With the advent of the coronavirus pandemic, Dr. Hassig has become a go-to source for public health information on efforts to stop the spread of the disease and has appeared in major media outlets ranging from the New York Times to Fox News. Our moderator is the incomparable Walter Isaacson, Leonard Lauder Professor of American History and Values at Tulane and the former CEO of the Aspen Institute, where he is now a distinguished fellow. Walter is also the former chairman of CNN and past editor of Time magazine. His most recent biography, Leonardo da Vinci, offers new discoveries about da Vinci's life and work, weaving a narrative that connects his art to his science. He's also a host of the show Amanpour and Company on PBS and CNN, a contributor to CNBC, and host of the podcast Trailblazers from Dell Technologies. Walter, I now cede the screen to you to lead us in what I know will be a fascinating and compelling discussion.
Thank you very much, Mr. President. Thank you so much. And thanks to all of y'all for putting together this innovation series. Deep in the heritage and in the genetic code of Tulane are things like the heritage of fighting for public health, which is how Tulane was formed, and innovation, which means how we're going to fight for it in the future. And there are no two better guests than Susan and Thomas to be part of our show today. Let me leap right in, and then we'll get to your questions, those of you who are joining us. But let me leap right in with Susan and say, do African Americans generally face a greater risk of being exposed to COVID-19 than other groups? And if so, why?
Thank you, Walter. Yes, in fact, it does appear that they do. This became very clear here in the New Orleans area and in the state of Louisiana once information about infections was overlaid on census tracts. And we saw concentrations in neighborhoods that were largely populated by African-American citizens of the state and of the city. But part of what places many members of that community at greater risk is in part how they go about their lives. They are often users of public transportation, which for coronavirus is an environment of close proximity and large numbers of people that can place them at greater risk of acquiring the infection. They may also work in a variety of jobs that don't allow them to, as many of us have, to stay home and continue to work. Their jobs place them on the front lines, whether it's in healthcare or in other service industries where they are interacting with a wide range and in often very large numbers of persons. And so by definition, in terms of how they are living their lives, they wind up being placed in situations and circumstances where they may very well be at much higher risk of exposure and then acquisition of the infection.
Hey, Susan, I already have a question popping up on the chat channel about just what you just said from Ernest Sneed. So let me tee it up for you and then we'll turn to Thomas, which is, did we lose some valuable time in understanding what you've just said and understanding COVID-19 by not screening in poor and highly impacted areas and in places where people don't have cars to drive to Oxford or in the suburbs?
We lost a lot of time in general because of the slow rollout of testing in this country. And if you'll remember, when testing began, it was focused almost exclusively in connection with travel to or exposure to those who had traveled to China. And the low numbers of testing, as well as that restriction, I think greatly hampered our ability to understand the impact throughout the entire US population. But I think particularly for the African-American community, we didn't recognize the problem until we saw the disproportionate numbers of individuals who were being hospitalized and then who are ultimately dying of this disease.
Thomas, both when you were at the Johns Hopkins, the Bloomberg School of Public Health, and now, of course, as our wonderful dean here at the Tulane School of Public Health, your field has been health disparities. Explain the skin you're in, that what you produce there, and how that applies to COVID-19 now, if you would, sir.
So The Skin You're In is a book and documentary film series that I've been working on. But when the COVID-19 pandemic hit and we saw that African Americans had were a disproportionate percentage of the deaths, we decided to turn the channels, the website and the social media channels, to this topic of COVID-19 and African Americans, to try to provide authoritative and accurate information and to dispel myths that have been targeting African Americans around the disease. Myths such as African Americans were immune to the disease, which may have led some people to be less careful and less likely to adhere to the guidance that coming from public health. And also to try to help explain what was happening. So as more data becomes available, we'll be able to better understand why African Americans are experiencing a disproportionate number of deaths. But when you look at some of these issues, for example, the United States remains a dramatically racially segregated country, so that if someone is infected, it's most likely that the census tract that they'll be going home to will be racially segregated. And therefore, while African Americans are more likely to work in hospitality or in other positions that put them at increased risk, they're also much more likely to be living in segregated Black communities, so that when they go home to those communities, it's other African Americans who are at increased risk of being infected.
I have a follow-up on that because I'm watching as states are trying to think about opening up or letting people back to work. It seems to me that we have a great divide in our society, partly along racial lines, partly socioeconomic lines, about work. those who have work where they actually have to go in, whether they're in the hospitality industries or for that matter, just keeping shop or working on the docks behind me, loading the ships, and those who are the knowledge workers who can, work virtually, work from home, can be socially distanced. Do you think that COVID-19 might take that divide in our society, which has already been bad and for the past 30 years caused economic and wealth disparities, and make that even worse?
It could. I mean, so as co-chair of the Governor's Task Force on Health Equity, we're not only tasked with trying to help the governor make good decisions going through the pandemic, but also to not take us back to the normal, but rather to a new normal that does not have health inequities. So we're looking at these issues and trying to think about how do we ensure that when we come out of this crisis, we don't exacerbate the disparities, but rather eliminate them.
Yeah, Susan, one of the things we did coming out of Katrina was say, let's not just rebuild the city the way it was, but let's build it the way we want it to be. What forces, cultural, socioeconomic, and historical might contribute to the prevalence of chronic health conditions and their severity in the African-American community in New Orleans in particular?
Well, I think there are many factors that contribute to that particular scenario that we see present in the data from Louisiana and from many other communities around the country. But here, I think the challenge has been the disruptions that have occurred even predating Katrina in terms of the public health system that was established in Louisiana long ago and was disrupted and largely dismantled prior to Katrina. Then when Katrina hit and wiped out the systems that were present, it was just really hard to get access to care. And so continuity of care is really important for many of these chronic comorbidities that we have heard so much about with coronavirus. Hypertension control is critical to maintain a reasonably healthy interaction with that particular condition. If you don't maintain control of your blood pressure, you can develop kidney problems. You can develop all sorts of more exacerbated cardiovascular conditions. And so I think the interface of just physical lack of access to care for a period of time, coupled with some distrust and lack of kind of continuity of care for many members of the African-American community here in New Orleans, for sure, also contributed to that on a very local scale. But one of the real challenges we have is, how we process healthcare as well, in terms of moving people through and the kinds of time you need to help people understand how to manage their diabetes or manage their hypertension has not been a focus of the way we have delivered healthcare for some time. I think all of those things have an impact.
Yeah, Thomas, let me turn it to you, both in Baltimore and in New Orleans, both places that have gotten hit pretty hard. What are the underlying reasons for the health disparities?
Yeah, thank you for that question. I think it's really important that we understand that there's an infrastructure that was created in part by a series of policy decisions that creates fertile ground for a pandemic like this to really take off in the African-American community, as well as communities of all disadvantaged populations and low-income populations. So here in the South, we have a low minimum wages. We have right-to-work states with very little union support for workers. So therefore, we have higher rates of uninsured people than we otherwise would have. Most of the states in the South refuse to expand Medicaid, and as a result, there are many people that don't have access to care and who have incomes that are lower than they otherwise would be. And as a result, people are less able to mitigate when something like this happens. They're less likely to have the resources, the financial resources, to be able to move into housing that's less dense, where there are fewer people living in the house and fewer people of different generations in the household, placing others at risk. Now, these are policy decisions that were made. These were decisions that were made by policymakers who were voted on by the voters. And as we think about how we're making some of these decisions, we still have an employer-based health insurance system in this country. So since we continue to tie access to healthcare to employment, access to resources to employment and policies such as minimum wage policies and right to work policies that lower wages and lower opportunities for people to mitigate, we'll continue to have these sorts of problems, particularly here in the South.
I see in the chat room my friend Greg Williamson, who's a great supporter of Tulane and helps organize our events at both Tipitina's and other places to support. And he's got a question. I'm wondering if somebody can unmute him and he can ask it. But it's really a question about what's happening now in New Orleans. Which way are the trends going?
Can you
somebody?
hear me?
Yeah, there's Greg. Greg,
Hi, everybody. I hope everybody's safe and healthy. Hi, Walter. My question really is, over the last couple weeks, have things gotten better in New Orleans? Because I last heard that things were quite bad for all the obvious reasons and the reasons that you guys are discussing. And I wanted to know what the latest state of affairs is. And also with respect to testing, is the African-American community and other disadvantaged communities getting access to testing the same way that others are?
Thank you, Greg. Who wants to start?
I can start with some of it.
All right, we'll do Susan. She raised her hand. Thomas, she beat you to the buzzer.
She did. Okay.
We are seeing great improvement in the New Orleans metro area. The numbers of new cases that are being identified are staying at a very low level. We have had a substantial decline over the last 2 to 3 weeks from a really devastating peak that plateaued for a period of time. And that is reflective of the generally solid adherence to the stay-at-home policies that have been put in place by the mayor and reinforced by the governor as well. We are seeing hospitalizations drop and ventilator utilization drop as well. And so we are in many ways in one of the best places with regard to containing and controlling what had been a horrific experience with coronavirus in the city. But there's tremendous concern that as we move forward to the anticipated reopening, whenever that occurs, that we need to have the testing capacity to identify if things start going wrong once again. The city has made a very concerted effort to get testing into disadvantaged and potentially high burden communities, particularly those who may not have had the capacity to drive up as some of the other community-based testing options were. They have put in walk up and bike up or whatever mode of transportation you choose. And they have been placing them all in areas all around the city for 2 to 3 to sometimes full weeks of testing availability. And I think that has proven to be a very important effort to try and increase access to information about infection status for members of those communities. We're on the right track, we're in a good place, but the concern is, of course, what happens when we reopen.
Dean?
Right. And I think the nature of the public health interventions that we've been using is such that if they succeed, it will look like we overreacted. And so there's concern that people will let their guards down because we've just had 2 pretty good weeks here in Louisiana. We also should point out that we are surrounded by states that have not been as diligently following these processes. You look at Texas; they're now seeing increases over the last 2 weeks, and I think we may start to see similar patterns emerge in the other states like Mississippi, Alabama, and Georgia that surround us.
I'm going to do a couple of questions I have here, and one of them is from Mike Thompson, and you're the co-chair of the governor's committee, Dr. LaVeist. Tell us about the policy issues and looking ahead. What public policies are the most essential?
Yeah. Well, I'm not sure if the question is about policies as it relates to coming out of the lockdowns, but we're spending a lot of time now looking at those policies and how we can open in a way that's safe. We don't have those completed yet, but there's a lot of discussion happening.
And what about long-term policies for the next, to try to prevent future pandemics?
Well, I should point out that these disease outbreaks happen all the time. if you go to the WHO website, they actually will list the pandemics by year, and they're constantly happening. This is bigger than most other pandemics. This is global and not just local like most outbreaks are. And this is a novel virus, meaning that humans have not previously been exposed to it. So these types of disease outbreaks are not uncommon, but for them to happen at this scale is what is common. So what do we do going forward? One is that we have to improve people's access to healthcare. We continue as a country, and to be the only country that continues to tie access to healthcare to employment. And if we stop for a moment to think about what is the logic behind tying employment and access to healthcare, because if you have a health insurance card, you get into the elevator with someone that does not, that health insurance card is not going to minimize your risk of exposure to this infection, right? So to protect all of our health, we need to ensure that everyone in the country has access to healthcare. So if I was to pick one policy, it would be disentangling access to healthcare from employment and ensuring that all Americans have the ability to get care when they need it.
I think that's going to be one of the things that'll really cause us a lot of thinking coming out of this, which is less partisanship and more discussion about how do we really get to a universal care. And I guess we can give a shout out to John Bell Edwards, because unlike other Southern governors, he turned out to be somebody who would expand Medicaid at least, right? Yeah. I see Lisa Rice is there, and she's got a question. Maybe I'll have her direct it to Susan, because Susan's a great epidemiologist too. Lisa, do you want to speak up? You want to get unmuted?
Yes, sure. Hi, good morning. I'm from Washington, D.C., where we have in fact identified our patient zero. And so I'm wondering, in New Orleans, was patient zero identified? And if that person has been identified, how have they survived COVID-19? Our patient zero survived. Long struggle in the ICU and on a ventilator, but he's back home. So I was wondering what's happening there.
Our first patient diagnosed and identified as COVID infected, which is one definition of patient zero, did not survive. And in terms of kind of thinking about how coronavirus came to New Orleans, we're still working on that. And in fact, some of our virologists are trying to sequence genomes of isolates from patients here in New Orleans to figure out what path they took to get to the city. But unfortunately, our first few patients also wound up becoming our first few deaths.
There's a question from Dan Michelson, which I'm not going to put to the panel because I don't think we know, which is what's Tulane going to look like this fall? He's got an incoming freshman. I'm sorry to say, I don't think Harvard knows, Tulane knows, Stanford knows. I will say I'll be around, so I hope he comes. I hope things are okay. And make sure that your incoming freshman takes my class so that I can get to meet him, Dan. And then we have Brad Ross. Where are we from a testing standpoint right now in terms of testing access? Is it easy for people to get tests, and is it equal in the city of New Orleans?
Yeah, it certainly has improved. I mean, we certainly did have a problem with that, with the drive-up testing, and people in certain communities couldn't really access the drive-up testing, many because they didn't have cars. The city has now gone to mobile testing, where they're bringing the test facilities into communities. And so I'd say we certainly have improved in that area. Where we still need to improve is in our ability to test for antibodies. We don't yet know how many people in the New Orleans area have been infected. And because we don't know that, we can't calculate a death rate, we can't calculate a hospitalization rate because we don't know the number of people at risk. So the antibody tests are, there are a lot of teams around the country, including here at Tulane, working on improving the antibody test. But what we really do need is a breakthrough in that area so that we can have quality, good quality testing.
I read in the papers yesterday that Roche has come out with an antibody test that's very accurate and rather fast out of Germany. Do we know if that's going to be brought here, or are there other tests like that coming soon? I'll start with you, Thomas.
Yeah, well, I don't know about that specific test, but I do know that there are a number of tests. In fact, I'm part of a team now that is working on conducting a national study of serologic survey where we're going to look at antibodies nationally, which is what we really need to be able to do for us to know just how many Americans have been impacted. We can't, what is the replication rate? How do we get to herd immunity? We can't really answer those questions until we have better testing. I do know that a lot of the tests that have been released, there was a study out in California that showed that of 14 tests, 11 of them were very inaccurate, 3 were moderately inaccurate. And so when we get to the point where we have usable tests that will be able to tell us whether we have antibodies, and then ultimately, does the antibody produce immunity, which we still don't entirely know just yet.
It's amazing how much we don't know in that regard. Jennifer Brush had a question, and then she lost her internet connection, and she's worried that the question already got answered, but it didn't. So I'm going to call on Jennifer. Somebody can find Jennifer Brush and unmute her. She's there, but muted, unmuted.
I'm in Cleveland, so
Hey.
I'm on the other end of the country. Thank you for taking my question. I was a U.S. diplomat, retired for 30 years. That's why I have foreign policy questions. And the first question, I'll keep it short, was the influence of China. We see China's influence growing in the developing world and new democracies as it becomes like the champion of finding the cure for coronavirus. And with that comes concurrent upsurge or uptick in anti-American and anti-EU feelings, because China seems to be coming to the rescue with their planefuls of medical supplies. So I was wondering what you thought about the rising Chinese influence and diminishing US influence in terms of how we're handling this pandemic. And the second question was about Russia. We see Russian troll bots continue to be at work on social media, and they're behind a lot of these demonstrations at state capitals. And the demonstrations at state capitals are now merging with the anti-vaxxer movement, which is also supported and funded by the Russian troll bot industry. And I wondered if there's a clearinghouse or any place one could go if you see an organization that looks suspicious to find out what its origins are and what its funding sources are. I specifically asked about Open Ohio, which is the group showing up with guns without respecting 6 feet, not wearing face masks, and becoming increasingly more belligerent. I would like to know where they're getting their information. Is there some type of clearinghouse that one can go to find out where they're getting their information?
These are both good questions, well, Jennifer, and I'm going to turn to Thomas to take either one. It's a jump ball, and then poor Susan will have to take the other. You get China or Russia. China influence or Russia trolls?
Yeah, this is very worrisome. We those Russian trolls are also may also be behind targeting African Americans with the inaccurate information, which also did lead to a slower response. So this is concern. So here at the School of Public Health and Tropical Medicine, we started a program called the Tulane Outbreak Daily. We hired a former member of the U.S. intelligence community who had been doing this sort of working on countermeasures to Russian disinformation. And this person is doing this for us. And what we do is to try to put out accurate information, non-political, non-partisan, accurate information, targeting, mostly it goes to the intelligence community. A lot of people, a lot of public health experts and policymakers have been following that. And so what we're trying to do is put out counter those efforts from Russia and China.
Can the rest of us see that, or is there a place we can get to it?
It's available to be to subscribe. You can opt in and subscribe to it. It's the TulaneOutbreakDaily.org. TulaneOutbreakDaily.org will take you to the website where you can sign up to receive this daily briefing.
And maybe I'm going to go out on a limb here, and you can shut me down. But if people aren't going to be able to subscribe to it right away, is there a way we could take one sample copy of it, like today's or yesterday's, and have maybe we can put it up on a website or send everybody who's part of this discussion a link so they can read one sample copy?
Oh, sure. If you go to the website, you can see every copy going back to
Oh, okay. It's not, you don't have to pay for it.
TulaneOutbreakDaily.org. It's free. All you have to do is just go to the website and sign up for it.
Okay, I thought we were making it a revenue stream. All right, Tulane, give the website address one more time, as we'd say.
TulaneOutbreakDaily.org, and it will take you to the website where you can see all of the previous issues and sign up for our daily briefings.
And Susan, you get Jennifer's question about China then, and I'll make it both sides of that question. China is gaining influence by some of the things it's doing, but also, as we read in the papers yesterday, a bit of a backlash, not just, of course, from the Trump, but from the European Union, a backlash against China too.
I think that this is a question that goes far beyond coronavirus in some respects, in terms of how all nations compete against one another for influence. And right now, because of long historical decisions about, for example, manufacturing of personal protective equipment, most of it's coming from China. And so they have that capacity once they reopen their economy after their outbreak experience. And so I think there are lots of forces at play there. And also, I think in terms of, what leadership stances a country takes and what efforts they make can also have an impact in terms of how the rest of the world views it and may turn to it in a time of need, and thus enhance or diminish its influence on a whole range of topics and concerns. I think coronavirus in many ways has ripped a veil away from a lot of underlying issues and problems that have existed within the United States and within the global population for a long period of time. And I'm hoping that when we get through this crisis, we can approach many of those issues to seek to improve them much more broadly and not just go back to the way things were.
And I'll add my 2 cents for Jennifer as a foreign policy person that she is. When you look at the history of American influence in the world, part of it has been military, part of it has been economic. But since the end of World War II, the greatest source of our influence has been our innovation. This is a Tulane Innovation Series. And the fact that whether it was the microchip or the internet or the personal computer or so many other things where we led the way in innovation, it led to America's influence in this world and for America being seen as a force for good. And I think if we're going to go into the 21st century and continue that, it'll be in the life sciences, it'll be in the public health, it'll be in dealing with pandemics like this. If we remain the most innovative nation, we'll also remain the most influential nation. And that's, in some ways, we competed against Russia to get our space race, which led to microchips and GPS. And now we may be competing against China in the race for influence and innovation when it comes to the life sciences. I see that Bill Marco, our board member, had a question about across Louisiana disparities, which would be great for Thomas to answer. Bill, do you want to ask it, or should I read it aloud if we can't unmute you? There's
no,
Bill. Whoops, you just muted yourself again.
Okay, yeah. There I am. Hey, thank you. And thank you for doing this. This is extremely valuable. My question was, do you see similar disparities in other parishes in Louisiana? I think I've seen some information about that. And are there any theories on, is it environmental? Is it, people's exposure to, healthcare or any other reasons? Thank you.
Thomas?
That's a great question. So what we do find, the disparities are pretty consistent in all parishes. There were one parish where we actually have a higher death rate for whites compared to African Americans. Every other parish has a higher death rate for African Americans, and in one case, the mortality for African Americans is 9 times higher than for whites. That one parish where there's a higher number of white deaths is a parish where a large number of deaths occurred within a veterans facility for senior veterans who died there. And if you take that out, you will find that even there were more African-American deaths than there were white deaths. So that's been pretty consistent. I really hesitate to push theories at this point, because right now I hear a lot of people who have sort of settled in on the narrative that the greater mortality among African Americans is because of underlying health conditions, chronic conditions like hypertension and diabetes. I resist drawing that conclusion just yet until we get better data on better antibody data, so that we know what was the rate of infection, so that we can actually create death rates and know if it really is the case that African Americans had a higher death rate, or if they simply had a higher infection rate, because the response would be quite different if it was the higher infection rate or if African Americans were dying at higher rates. The narrative that African Americans are dying at higher rates because of underlying chronic conditions, I don't think is fully satisfactory, because white Americans in Louisiana also have extremely high rates of hypertension and diabetes and these other chronic conditions. And the disparity between Black and whites in these conditions is not great enough to explain the disparity in COVID deaths. So there's more complexity to this, and I resist pushing theories until we've really had an opportunity to understand the data a little better.
And Brad Beers, also on the board, had just asked about public testing access. Is it equal in terms of the time that you get it back? I was wondering, Susan, is that the case pretty much?
Well, certainly the time of return of results has been improving as the availability of, the media and the reagents and everything else has gotten smoothed out somewhat. The PCR-based testing is still a longer time to get a result than some of the point of care kinds of options that people may have heard about that can provide answers in 5 to 15 minutes. My understanding is that still the mobile service testing that is being done, for example, here in New Orleans and in other locations around the state of Louisiana, is still the PCR-based testing. And so it's going to take potentially a day or two, because the sample has to be sent to the testing facility. It has to be processed, usually in batches, and then the results are reported back to the person being tested and then to the state.
Well, the upside, though, is that even though it now takes about 24 hours for what we call the PCR test, it's actually quite a bit more accurate and specific than the 15-minute test, right?
Well, it is. When you get a positive from the PCR test, it is much more definitive. The challenge with the PCR test is that a negative test is a little bit more challenging to understand. It may be that you are infected and are not yet producing enough viral particles to be detected. There may be issues with how the sample was taken. A variety of things can result in a negative test, the detection limits of the test itself. But a positive test is considered definitive if you receive one.
Sandra Robinson has a question. If we can find her and unmute her. There you are, Sandra.
Hello.
Hi. We hear you.
All right. I'm from New Orleans, and I know there's a history of African Americans fearing going to the hospital. Is there any type of history behind that? In New Orleans, pre-Katrina, we would say things like, you check in, but you might not check out. So I know even with the COVID-19, I have family members that are still very sick and refuse to even go and get a test.
Wow.
Well, we do know that this is really, I've been hearing reports about this around the country, not including New Orleans, but not only New Orleans, that people are hesitant to go in to receive healthcare for other purposes for fear of acquiring the infection while at the hospital. I know this is a new issue that we're going to have to address. And overall, this issue of African Americans and mistrust of healthcare, this is a long time problem that's been around for a very long time. And it comes from a very real place. Historically, there have been, untrustworthy acts that have been perpetrated against African Americans by healthcare which justifies that distrust. So this is a real problem that we have to overcome, and programs like the Skin You're In program, trying to address these types of issues is what we're going to need to make progress. By the way, I didn't get a chance to mention that the Skin You're In's website is tsyi.org. That's the initials, the Skin You're In, tsyi.org.
Great. We have a undergraduate student studying public health, Shamila, and she has a question if she can be unmuted. There she is. Shamila Masari. Yeah.
Thank you guys so much for presenting today. Yeah, I'm studying, I'm currently undergoing a bachelor's in public health. I'm actually on the logistics team of the Skin You're In Health Education campaign. I just joined a couple weeks ago and I'm really excited to be a part of it. So basically my question was just kind of wondering, you talked a little bit, Dean LaVeist, earlier about how you're working with the governor to come up with certain types of policies to sort of like to prevent an aftermath or a second wave of infection from coming after some of the more restrictive stay-at-home orders are lifted, you know, when you see an upwards trend or a downwards trend in infection. But I'm wondering how these state policies are being interfered by, you know, the national administration when President Trump kind of contradicts science and contradicts facts, and does it make it difficult for states and for governors to come up with policies that either contradict what he says or, you know, like contradict science and things like that? I'm wondering if you find any resistance in that area.
Well, I have not, with the Governor Edwards' administration, I have not found any cases where people have been hesitant to not follow the public health and the science knowledge. So we've been coming up with policies, and as we work out the policies, they'll be based on the science about what we know about how the disease is transmitted and what best practices we can identify to put in place practices that will reduce transmission. That's been my experience to this point.
Rebecca Santana, a really interesting public service question, if we can get the answer to it. Is Rebecca there?
Yes, I'm here.
Go ahead.
Hey, so I have seen lots of advertisements around town for antibody tests, and you know, I'm a reporter. I've received press releases for people saying $115 you can get an antibody test. How reliable are these? And I mean, how should people be assessing these and whether they're worth it?
You want to take that one, Susan, or shall I?
You did it once, maybe in the second message we'll get through. Antibody tests right now are not something that I would go spend a lot of money on, because we have a lot of not well validated testing methodologies that are available. And so I think we are still trying to fine tune that process. And so I think we have to be really careful about the testing methodology itself. We've seen, as Dean LaVeist mentioned, an assessment of 14 different serologic tests where only 3 of them did moderately well, which means that they're probably not worth using right now in any kind of individual basis kind of utilization.
Oh, sorry, go ahead, Susan.
No, that's good, that's fine.
Let me let Paul Flower, if he's actually on, because I see him in the chat room there, who has some real connections and understands Ochsner. He had a little bit of information that I thought was useful. Paul? Want to hit that unmute button? Yeah, Paul, there you're on.
Okay. Ochsner uses an Abbott test, which they tell me they feel is fairly accurate as a serological test. And they've used it to test all their employees. My wife and I got the test, and both of us are positive for it, which we think we had in early March. They tested their employees, all of their employees, and came up with a lower percentage of positives than they would have expected. So that's what I know about that. They are going to make that available to the public early this month, I believe. So I'm not, they were fairly confident of it, but I'm not a medical person.
All right. Well, yeah, the Abbott test is getting a lot of publicity these days. I see Alexandra Silva had a question. I'm wondering if we can pop her in, which is about communications. Did we find her? Silva, S-I-L-V-A. All right. While we're waiting for her.
While we're waiting, Walter, if I could chime in.
Yeah, please, Susan, yeah.
I think the real challenge for a lot of the antibody tests is having a big enough pool of known infected and known non-infected individuals to validate the antibody results. And so healthcare workers who have, in many cases, been screened for viral infection may be one of the good populations to use to validate serologic tests, because you'll know who had a positive viral test, and you can see whether that antibody test consistently and hopefully 99 to 100% of the time identifies them as having antibody positive. But the other piece about antibodies is that not everyone generates the same kind of antibodies and the same level of antibody response. And so that's one of the other challenges with antibody testing as well.
Yeah, but Susan, I mean, what you just said is fascinating. We have, thousands of people who have now tested positive. We know who they are. Wouldn't it make sense right now to go back to as many of those as possible and give a serological test and say, all right, do you have the antibodies, and assess the antibodies, see if there's a different types of antibodies or different levels, and people have already had an exposure to the coronavirus.
It certainly would, but that's only half of the testing process. You have to know that a negative antibody test means that you were not infected. And that's a more challenging group to identify because of some of the nuances of the actual viral detection testing methodology. Just because someone tested negative once doesn't mean when you go to do the antibody test that they might not have actually become infected in the interim. So finding the negative pool is actually one of the more challenging parts of validating the antibody test.
I got it. And it would seem to me that one of the most important questions, but one of the most straightforward questions is, does the antibody confer immunity? How come we haven't been able to figure that one out?
That's a really difficult question, because you have to remember that we have only been recognizing and working with this disease since, I'll be generous, November. Maybe December. And so we are only at the beginning of May. That's not a lot of time from a biological science perspective. Certainly there's very encouraging information coming out of the primate modeling that some research centers have been doing that suggests that non-human primates, when challenged after having been tested positive with antibodies, do appear to be resistant to a second infection. But that's going to be a really critical component again. There are different kinds of antibodies that your body can produce. Some of them are neutralizing and can combat a virus, for example, but others are more markers. If you'll think about HIV, the antibodies that people develop to HIV do not control the virus. And so while in most viral infections, we do develop antibodies that are at least temporarily protective, that's the other question, whether if they are protective, how long will they be protective? And so immunology is a really complex area, and we're still trying to answer a lot of these really important questions. I do think there's encouraging evidence that would suggest at least short-term immunity for most people that are infected. Long-term immunity is something we haven't had time to assess.
I see Angie Bennett has a question about mask use. I'm wondering if we can call her up. There's Angie. Nice picture there. Yeah, Angie.
Hi, Professor Isaacson. I also have Evan here, so he's in the background.
Who's that?
I've got Evan.
Oh, cool.
My question about masking was whether you guys, we're in Ohio, so that's been a hot topic here lately. Is that something you are looking at mandating there? Do you see differences across demographics in terms of who would be willing to wear a mask? We're getting our governor flip-flopped pretty quickly on mandatory mask use being, and then flipping to saying that he got pushback that it was offensive, basically from a personal liberty standpoint. So just kind of wondering what the attitude there is in Louisiana and New Orleans, especially with, you know, Tulane and the kids coming back as a possible way of making it possible for them to return to class. So
I'm going to turn that over to Thomas, but I do want to mention for those who want to know who Evan is, he was one of the best students I ever had at Tulane.
Is the question about mandatory use of masks, or what specifically was the question?
Well, I think I'm wondering what the approach is there with you all, and whether, I mean, it seems to me that mandatory mask use would be, makes sense. But I'm wondering if you all have, you know, if there are maybe some demographic differences as to who would be, if there's any pushback in terms of, you know, being willing to accept a mandatory order, or even on a, if it's not mandatory, whether you think that even makes sense from a public health standpoint. I actually thought it was really interesting. I was in a fabric store buying mask making material, and a third of the people in there buying mask making material were not wearing masks. So, you know, and it was all tended to be the older generation. I don't mean to, it seems like the very young and teenagers are not wearing masks, and the older generation seems to have this personal liberties issue. At least that's my very non-scientific observation.
Why don't we let Thomas take on the question of how do we get people to wear masks?
Let's hope that they weren't wearing masks because they were in the store to buy the materials so they can make the mask and then wear it later. Because I think everyone should wear a mask. If they go out in public, they should absolutely wear a mask in every circumstance. So we are still working on what the policies will be for reopening the university, as well as what the policies will be. I've been consulting with the restaurant industry, the gaming industry here, and so we're still working on what those policies are going to be. And I don't want to get ahead of that because there'll be an announcement about that in the next few days. But I think masking will assuredly be a part of those policies.
Well, maybe we have a tradition of masking in New Orleans, so we'll be better off. I will give a word of praise to the Vice President Pence, who did not wear a mask on the Mayo Clinic visit. Politicians don't often do this, but I just saw this morning that he apologized and said he should have, and that he will be doing so. It's important, I think, for our leaders to show real leadership. Let's see else we have here. By the way, somebody asked, can you put the Tulane Daily Brief link, the thing that Dean LaVeist talked about that Tulane Daily on the outbreak link. And Dean LaVeist is very good at Zoom, because if you look in the chat room, he posted the link right after the person asked the question. So if you're looking for that link, there it is. Let's see, Charlotte Hankin.
Hi, can you hear me?
Yep.
So I'm an undergraduate junior at Tulane, and I'm studying ecology and evolutionary biology. And I've become very interested in this topic as this pandemic has become a more present thing in our lives. And I've kind of gone down the road of infectious diseases, but I have some past lab experience and backgrounds in genetics. And I was looking into, I really want to help out what kind of opportunities I might have to like volunteer somewhere, or any kind of lab opportunities that might be open. I was having a really hard time seeing if there were any. So I knew like where those connections, okay.
Thomas, I mean.
Well, I mean, Susan may know about lab opportunities. I'm not aware of that. I do know that we are recruiting contact tracers, and there's going to be a need for thousands and thousands of people to volunteer to help with contact tracing. And so those opportunities certainly will be around.
In terms of laboratory opportunities, it's going to be Tulane's faculty, both in the School of Medicine and the School of Public Health and the Primate Center have been, and I suspect will continue to be, quite successful in terms of getting research funded. And that is a big driver of laboratory opportunities for students to get that experience. But I think your area of ecology and evolutionary biology is a really fascinating one as it relates to coronavirus, given that this was precipitated by a zoonotic spillover event. And so I think that that area is one that will be increasingly fascinating to study as we move forward and in your remaining time at Tulane as an undergrad.
I do think that this is getting a lot of undergraduates to think more about studying biology, zoology, and other things, which is good because the life sciences will be the type of innovation we need in the future. I see that Dan Michelson, whose son Ian is coming to Tulane in the fall, asked me a question, which I'll answer real quickly, which is about the lack of collaboration as different companies compete to try to find a vaccine, and how do we mix collaboration and competition. Competition does help drive innovation. It always has, and the ability to compete and win a race, sometimes even patent something, helps drive innovation. However, we do have a history in this country, the most famous of which was the Salk vaccine, where people collaborated and where it was not only a collaboration of academic labs, as well as government labs, as well as private industry, but the March of Dimes was founded to help do the clinical trials and pay for it. And as a result of that collaboration, the Salk vaccine became open, unpatented, and was widely and inexpensively available. I think that one of the things I try to teach in my course, and I can't do in this one webinar here, is what mix of competition and collaboration do we need in all industries? And I've seen that Berkeley and versus MIT, the great patent battles we've had so far in the area of genetic editing, that the two are now collaborating and putting everything involved with coronavirus up for free on medRxiv and bioRxiv. So I think and I hope that in times of crisis like this, we can still remember the importance of competition and intellectual property, but we can put that aside for the public good. Thomas, in the small time we have remaining, I was wondering, there was an op-ed piece that you and President Mike Fitz signed in The Advocate a couple days ago. It was about a MacArthur grant that had been submitted a while back from Tulane, but it was about the need, it almost goes right to this question of Dan Michelson, the need to have public-private partnerships and get things right. And the fact that even Tulane is now doing that with the pharmaceutical industry as well as data. Explain the theory behind what you all were pushing there.
Yeah, what we were talking about was the creation of an early warning system, so that when these outbreaks come, that we have early notification that these outbreaks are coming, and that we can begin to deploy the university's assets along with our private sector partners to address them. You know, we're the only university that has a School of Public Health, School of Medicine, and Primate Center all here at one campus, which gives us tremendous resources in this area. And unfortunately, we weren't supported in establishing that center, but this is definitely something we're going to be looking at going forward, establishing this kind of early warning that allows us to get ahead of these sorts of outbreaks, and may have helped flatten that curve and reduce the number of deaths that we're seeing in the country.
Susan, any final words from you or thoughts about where we should be going? Unfortunately, there's so many more questions here, but we're going to have people come back to these things. We can't make them take their whole mornings.
The last thing I think I would like to close with is I think that we do have substantial information and evidence that we can influence the impact of this particular pandemic on our populations, on ourselves, by doing the kinds of actions that have been promoted by public health experts and scientists since the very beginning, which is physical distancing to prevent easy spread, utilization of barriers such as cloth masks, and then recognizing that we are all in this together and that it's really important for us to act as communities, whether it's a small local community or the large global community, to really take hold of this problem and join together to try and keep it under control. We don't have the perfect toolkit. We don't have perfect tests. We don't have a vaccine yet. Therapeutics are not yet here, but there's still a lot that we can do. And it's incumbent on us to all contribute to that.
Thomas, any final thoughts on that? And also, when you say there'll be a whole lot of contact tracing, maybe you could think of a way, and we'll try to get the word out, if people want, Tulane students want to be contact tracers, is there a place they can go sign up and do it?
We are working on that. And as a matter of fact, my very next meeting after this will be on this very topic. And so we'll put out an announcement. We'll certainly send it out through the listserv so that students can get it, how they can volunteer to become part of the contact tracing team.
Well, thank you. I think everybody's looking for something that they can help do. And perhaps if you put that on your daily newsletter too, you've probably gotten a big bump in circulation from this webcast. I want to thank Thomas, who's just been, a godsend to the city of New Orleans that you came down here from Hopkins. And of course, Susan has always been a backbone of our community at Tulane. I want to thank all of you who've been on this virtual lecture. I'm kind of having fun with these, and maybe we'll all learn new ways to learn things. Thank you all for being with us, and see you in the next time.